education. Asino company, it's a huge company, but it is the first to be in Egypt since a few months. It is, we know here, and we know all the people there, they are starting immediately in continuous medical education, and they agree to take part of this, sponsors this part of cooperation between Ru'ya and Egypt Gastro, and also the Italian side. So it's live cases, so it's combination of things. So thanks, Asino, for sharing this continuous medical educations, and all the people which I dealing with them, Dr. Hassan, Dr. Nabil, Dr. Arfan, Dr. Shuk, all of them, they did a very hard work with me to continue with that. Then I'd like to thank the people behind the camera, which is coordinating all the mails, everything, and all the processing of webinar, which I think is very difficult. So I think like to thank Ru'ya by names, Marwan and Nuran, because and Heba also, because these people who are creating all the things to be online. So these people working beside the camera, but to let us to be in the front of the camera. So I'd like to thank them very much for their effort. And then we will start now the first introductions of me. It's a simple lectures. And then we start by lecture of Professor Roberto. So I will share the screen with my lectures. Yes. Okay. I would like to thank also the who sent me this many of these slides from Norgine, because I get benefit of this slide too much. So it is 50th year of colonoscopy milestones, but in the same side, I like to say to everyone that my journey of colonoscopy, it's since 42 years also. 42 years when I started colonoscopy. So if the history started with 50 years, I started since 42 years or 41 years. So so I'll make a screen show. So in 1807, this is the first publish of Dr. Philip in his book, so he can observe inside the human brain the rectums by using only a light coming from a candle with a concave immer, but he can see what inside. This is the beginning of to see what inside. This in 1853, the first instrument of clinical values called the endoscope. It's a gas gene lamp filled with alcohol, and this is published in a book in 1865. And they observe the bladder, urethra, and they can also see the rectum. And then after that, you know, all of you know about in that time, in 1879, Thomas Edison with discovery of electricity and the lights. So this is the beginning of a change of everything at that time. Then Schultz, the first single contrast examination of the colon done at that time to see what inside the colon by using oily suspensions of bismuth. Then this is also 1950, Olympus Optical developed the first practical gastro camera. Then this is a very, very important one in 1957, where Hirschwartz and his colleague, the first fiber optic endoscope to observe the gastrointestinal tract for the first times. And then 61, he and his colleagues produced a prototype endoscope and created what's called Hirschwartz fibroscopes. Then 64, the European Society of Gastrointestinal Endoscopy was established, ECGE, at that time to promote the quality of endoscopy. And you should know that they publish their first guideline about polyp preparation in 2013. So it took a long time. This is what's called fecal-occult blood, was introduced as screening test for colorectal cancer in 1967 to detect a polyp or a cancer. Then this is maybe one of the what's called 50 years, where Dr. William Wolf, Dr. China, performed one of the first modern colonoscopy in June. In September, they complete the first endoscopic examination of polyp anywhere in the colon. So I think this is 1969. It's the beginning of colonoscopy since 50 years. The first chroma endoscopy of the colon in 76. This is a start to my journey, which is not too much from, since I think 41 years in 1979, when I started my first doing my thesis on, at that time was called the bilharzia polyps, and I did my master degree and my MD degree. So I worked by colonoscopy starting from 1979, maybe until when I finished my MD thesis after. So I have a master thesis, MD thesis, all of them about bilharzia polyp, colonoscopy, polypectomy, proctoscopy. So I started by dealing with the colon and with the rectum since that times, with many publications and all my thesis on that. Then, Noreen, for me, I don't know for others or not, they think Noreen, it's a new company. No, Noreen in 1980. So since more than, speak about 40 years, Noreen licensed the Cleveland Prep, the first specialized polyp preparations. So since 40 years, we know Noreen when we speak about, as I said, that paper prep, but it's a very old related to the colon history or the colon generally during the last 50 years. So since 40 years, they are in. And then Olympus in 82 introduced an ultrasound endoscopes, and then Walsh Allen cooperated the video scopes, which is image on the video screen. It is 83. In the same time, Fuji and Olympus produced a video scope in 85. Then 1992, the first European gastroenterology meeting was founded. And the first week, it was in Athens. And I remember I presented in this meeting the first paper on band ligations of the viruses by the old one, which tube over the endoscopes. This is in 1992. And then after that, all of you, Dr. Kudu, he did a classification of the colorectal, what's called the beat pattern. 2001, which is another thing, so it is a camera which you can adjust with a wireless capsules, and this is another breakthrough for the colon and for colonoscopy and for examination and technology. Then 2002, Olympus launched the new device Lovera, which is the first high definition endoscopic video systems. And in the same time, they have the scope guide system. Scope guide system was launched in 2002, but I worked with Christopher William maybe 10 years, more than 10 years. In the late of 1987 until 88, he starting this scope guide, and he showed me the beginning of that. But it was launching on 2002. 2003, which is also a breakthrough for the colon and small intestine double balloon by Yamamoto. 2004, this is the first European umbrella patient organization dedicated to the colorectal cancer was established. This is another breakthrough, which is 2005, when I said Norgine. In this study, they said that to study that colonoscopy is better than anything to detect cancer colon. with less invasive screening techniques. And at that time, Norgine launched the Mivprep, which is a polyethylene glycol. And it's offered the first lower volume based foul preparation. So they do something since 40 years and something since about 20 years. And then Olympus introduced the narrowband, all you know about that. And then 10, the European guideline for quality assurance of colorectal cancer, and diagnosis was established. 13, this is another what's called fuse endoscopes or endochoice. They launched this endoscope has a 3 camera, so it's the wider of visions, and they make innovations. And one innovation is from Norgine, which endocuff vision. So this is working through that. And then the third eye work from advanced in 2016. Then in 16, Fusion launched the new system, Referra systems, with multi-light technology systems, was linked with color imaging and the blue light imaging. And this is a combination of different wavelengths, which is also a new breakthrough through endoscopy. 2017, it is a capsule robot. What's mean by that is you can get a capsule, but you can detect this from outside by external robotics arm, which is something new. Remember, although in 2017 in Europe, Norgine launched the Bliven, the first 1 liter polyethylene glycol. We don't, I think they have it. I don't know if Roberta, they have it in Italy, based power preparation for cleaning of the colon prior to any procedure, consisting of 1 liter of clean fluid and 1 liter of power preparation. It's the lowest volume of BEG-based power preparation to date. So it is a long story. This is another thing which is 2018, Norgine and Olympus Karl Storz, we make a workshop in Athens. So they also Norgine help training in Africa. But in this webinar, I like somebody from Norgine to be with us. I'd like to put a slide, but I remove it. We work since 2004 with African, and we train more than 300 doctors from all Africa. We create mini unit in Addis, and I think the team unit which workshop is done in Athens. It is my unit which I established since more than 7 years in Addis, and then we established many units. So I think we in the future we'll have a very good work with Norgine and with Athens, with Athena in Africa. What's in the future? In the future, it is robot assistant colonoscopy system, now produce softwares, more slender, automated, designed to improve patient comfort. This is the future of colonoscopy. So if you look for what happened to Norgine from here, 1980, 2005, 2013, 2018. So all this year, Norgine working with colonoscopy to improve patients' quality and to improve quality of colonoscopy and add many things, because you will see immediately how to perform perfect colonoscopy. To become an expert colonoscopist, you should be aware of what's called unconscious inexpert. You should be aware about the techniques of colonoscopy, of preparation, about everything. This awareness, it is remove you from this situation with unconscious and expert to become conscious, only to become conscious. You should add motivation, because as Dr. Ayman and Dr. Roberta, I think many of the doctors, us in the webinar from all over the world, these techniques of colonoscopy need some motivation to do it. It's not like an upper endoscopy. It's not like ERCP. It should finish up to the ileum. So the colonoscopy is not to get, but to finish up to the ileum and to see all the fault. You should have an awareness and motivated. If you are aware and motivated, you become conscious, but you are not expert. and then you should be trained, either trained by virtual trainings, by hand-on trainings, by simulators or something like that. And need a long time of training, and did what we did in Africa in the last 17 years in all over Africa and in Cairo Training Centers, which is WGO Center. When you have training, you start to practical. And when you practically become to persistence in that, and you reach a conscious and expert. So remember, it's a long story, and you should do that if you like to be a very good colonoscopist. So a perfect has three components: complete and comfort integration, detect all the pathology, safe and complete therapy. What it have changed in the last decade: use of split dose of the same day or the same day bowel preparation, which is done by Norgine, which is increased perfection of colonoscopy, carbon dioxide inflations, water immersion, and you expect complication, deep sedation, aspiration pneumonia, spheric injury. So you expand your awareness of complications. But have a change also, you can thin flat the present serrated polyp. It need adequate lumen distension. It adequate clean of the stool and the mucus and the bubble. So remember that cleanness is very important for that. Adequate time and working with a fold. You should be examined the right colon twice. Retroflexion and the proximal colon should be mastered. Expand your snare option. Consider high risk pulmonectomy sites. This is an old one. So moving from absolute number to quality. Normally, many people said, how many colonoscopy you did? I said, I did 100. I did 300. It's mean nothings. It's mean nothings in the era of colonoscopy. The quality indicators. What is the quality? It is a good bowel cleaning and use of sedations, more than 70% of the cases. You have cecal intubation in more than 90%. You have our withdrawal more than 8 minutes, which is very important. You can resect polyp less than 2 centimeters in all cases with extractions of them in 95% cases. You should have adenoma detection in more than 20%, and if the fecal blood is positive, more than 40%. You have a perforation rate of less 1 per 1,000. By that means, and reduction of cancer during surveillance. So this is a very important thing. Before that, they don't speak about quality. Now we speak about quality in endoscopy, and quality should have a good cleaning of the colon, good intubation, withdrawal time, and all what I said. This is the last slides for me, but before I finish, I like to say that during colonoscopy, I never see any because I was trained in United Kingdoms, and I visit many areas, and very little ask where is the woman in endoscopy. But now, by this team of women endoscopy, I think I just like Roberta for what they create, because I think it is very important, and the number now is markedly increased. So the last slide, it is remember that today trainee, tomorrow are endoscopists. This is normally become endoscopist after training. And today trainer, like me and Ayman and Roberta, which is training, tomorrow may be patients. So take training seriously and do it properly, because your trainee, he will endoscope you. So take care of that. Waiting for all of you, Ayman, Roberta, and all of you. Until now, I still going in December, which is, I think by December, everything will be finished, but we'll take the last decision after 2 months, by still in our planning with everything, and Roberta with women in endoscopy also in this meeting, if it happen, and I think it will be happen, not in Cairo, but happen in Garda, but we'll see. Thank you very much, and I think we will let the lectures of Dr. Perta, and then we have a discussion after that. Thank you.
So we knew and we learned how to classify the polyps, the lesion, and why should we screen. So now what to do when we find a polyp. So just to summarize, when we have a lesion, we have to know how to approach it. The first is the characterization. So to look at the morphology again, to the glands pattern, to the vascular pattern, but then we should have a pre-resection stadiation. So we should know how deep this polyp is going. Is it still superficial or is going deeper? And from this, all of this, it depends our therapeutic management. Is it still an option, the endoscopic resection? That means polypectomy, EMR, piecemeal EMR, the CARB, the knife-assisted endoscopy, or the ESD, or should I send that lesion and that patient to the surgeon? If we look at this definition, this is a very old definition. It was done in 1995, but they say that a neoplastic lesion is called superficial when its endoscopic appearance suggests that the depth of penetration in the digestive wall is not more than the submucosa. And I think that every single word of this definition is important. We have the endoscopic appearance. It means that we must learn how to look at the lesion and how to characterize the lesion. And then it suggests, so we are just guessing the histology of that lesion and the penetration, the depth of penetration of the lesion in the gut. This is why the classification is so important. I don't want to go deeper in the classification because we had a very great lecture about it. But just remember that all the classification that we have is crucial to understand what to do with that lesion. So it's important the morphology, because the morphology together with the dimension, with the size of the polyp, is associated with a different risk of submucosal invasion. That means lymph node involvements. So the polypoid, non-polypoid depressed, that is increasing with the size. And then we have also the morphology with the pattern classification, with the Kuto classification that we really saw, but also the LST, the lateral spreading tumors, that they have and they own different risk of submucosal invasion depending on the type. So look at here, this is it's becoming a very famous paper. It's been published very recently. The granular homogeneous type has a risk of to be invasive in 0.5%. This means that we can resect this type of lesion in a piecemeal fashion. We don't need an en bloc. But look at the non-granular or non-granular pseudodepressed type. Is 30%. It means that this lesion must be resected en bloc. And then we have also other papers, even this one from the Burst group. We have the risk classification for covert invasive cancer. So we said that we have an invasive pattern, 5, the location that is a rexus sigmoid. When the polyp is increasing in size is more than 40 millimeter, or there's a gross morphology with nodules, there can be an increased rate of covert cancer on that lesion. So again, we found the lesion, we assess all the morphology, the pattern, the vascular pattern, so what to do, how to remove it. Basically, we have 3 types of technical resection. We have the simple polypectomy, we have the EMR, that is endoscopic mucosal resection, and then we have the ESD, that is endoscopic submucosal dissection. But the main question is EMR different from polypectomy? Yes, because of multiple things. One is the morphology of resected specimen. The polypectomy is for polyp that most of the time are pedunculated, so we are just cutting the stalk of the polyp. But when we are facing a flat lesion, a non-polypoid lesion, even the depth of cutting is different. So in this case, we made the submucosal injection to get the lesion elevated and to get, let's say, became polypoid. So we go to the guidelines. Every time we have guidelines for everything. It seems difficult. Every time we have some algorithm to be followed, so I try to summarize in this way. If during our colonoscopy we find small polyps or polyps up to 5 millimeter, we can go directly for polypectomy during the same colonoscopy. But if we found multiple polyps, let's say more than 3, we should plan the polypectomy in one or more sections, but this one depends on polyp characteristics on the side, but also, this is very important, from the endoscopic skills. But if we found the advanced polyp, more than 25 millimeter, or difficult polyps, depending on size, morphology, and location, if we don't have in our hands the skillness to resect them, we should refer them to specialized center or to surgery. And specialized center is the one able to perform EMR, complex EMR, and ESD. So how to resect something that is already, that we suggest that is already an early colorectal cancer? It should be performed en bloc, because en bloc allows us a precise staging and a careful evaluation of the lateral and vertical margin, but should be done in a radical way. It's an oncological complete resection. This is the so-called R0, because we need to determine when, how, and how deep resect the lesion. So if we come again to the guidelines, these are the guidelines from the American Society. We should divide the EMR into cold snare EMR, the injection assisted, where we inject the submucosa, the cup assisted EMR, or the ligation assisted EMR. These ones honestly are more common for the upper GI, not for the lower GI. But all of them, they can be done in a piecemeal EMR fashion or an en bloc session. Let's check a video. This is a movie or an en bloc EMR. It's nothing special. We found this lesion on this fashion of melanoma in this old patient. We were in the ascending colon, and this lesion, if we saw carefully, is a serrated lesion. But because of the size, we decided to remove it, if possible en bloc. If not, we were able to remove it piecemeal. We inject the lesion with the so-called dynamic injection. That means to push the needle against the wall and then withdraw gently the needle to find the right plane to inject the solution into the submucosal space. Once injected, we shift to the snare, and carefully we try to take all the edges at the border of our lesion inside the snare that we choose. We push the scope to stay in a stable position and to check and take all the borders. We close the snare and we cut it. There's really nothing special in this EMR. This is the, let's say, the basic of EMR. We apply the current, and it's done. But there are some different polyps. That one was, let's say, easy, if you pass me the term. But we have different advanced LST granular mixed type, for example, that require advanced tissue resection. Look at this one. Is it possible to really check the extension of the polyp only if we retrovert our scope? And we are in the transverse colon. So it's a big lesion. It's a complex lesion, because if we look at the morphology, we have some big nodules, but at the same time, we have a lot of difficulties, not only coming from the lesion, but also from the position of the lesion, because the most part of this one is visible only on retroflexion. So we apply all we have, the morphology, the chromendoscopy with LCI and BLI to check for potential invasion, and we decide to go for piecemeal because the position was too much difficult. So the first step is injection again, then is the snare resection, and we try to take as much as we can the regular and normal mucosa around the lesion to have the force snaring of the part of the lesion that is up to the scope. And then step by step, by injecting and resecting, we'll place the snare just near the previous snare resection in this way, so it will help us in grasping the lesion. And in this way, we were able to isolate the big nodule, the central nodule, from all the rest of the lesion in this way. And because the possibility to have a covered cancer is just under the big nodules, we tried and we were able to grasp and take the big nodule in one piece, and we send to the histology this nodule in a different ample. And in this way, step by step, we finish. Sometimes you can use what you're using, this way the tip of your snare to make coagulation, because later on we'll also talk about the safety and the possible adverse events related to advanced tissue resection. And this was the end of our resection. But we can also apply the underwater EMR. This is very nice because doing underwater, mostly for fibrotic lesion, you can use the floating of the lesion on the muscularis propria, on the muscle, to have more space to place your snare and to remove it. So most of the time we are doing something that is mixed in between. Some part is underwater, some part is with CO2, so it depends, and you are compromising with what you are facing. But what happens if you have a lesion that is more than 2 centimeters and all the features you are evaluating suggesting that is a depth in the submucosal invasion, so it means that you want to remove it and block, but it's more than 2 centimeters. So with just your snare, you are not able to remove it in one piece. This is the rationale under the ESD. This is why the Japanese colleague, they started to perform ESD, to remove lesion bigger than 2 centimeters in one piece. So this is the main difference between the two. And the first was done in this way because there was no devices available for ESD. So Professor Yamamoto in 1999, he published the first ESD that he did it just with the tip of his snare because he found this lesion that was in the rectum, a 40 millimeter flat elevated, and with the tip of his snare he was able to remove it and block. And this was the first ESD done all over the world. From that point, we started to debate, is it ESD or EMR? What should I do if I found a polyp? The fact is that the EMR, let's say that it's easy and well established. It's not so easy because it's depending on your skillness and depending on the polyp itself. But it uses standard devices, it's relatively short, with low risk of complication, but the pathology is uncertain because I'm giving all these small pieces to the pathology and I'm asking him, tell me if the depth and the lateral margin. He can't because it's just small pieces one by one. Of contrast, this ESD is technical demanding because it's difficult. You have dedicated devices, also the cost is different because you need some different devices and long lasting. You have a high risk of complication, but the pathology is accurate because you are giving something like this to your pathologist that is different. And in this way, he can answer to your question. So let's say that you find these two different lesions in this column. The first question that we should ask is, should I do it piecemeal or en bloc? And the second question, depending on piecemeal and block, because the big difference between EMR and ESD, if my choice is doing piecemeal or en bloc. So depending on the answer to this question, the second one is EMR or ESD. Let's go again to the guidelines for the ESD. If we look at the European guidelines, they say that ESD in the colonic indication depends on the morphology of the lesion. So again, we come back to the suggestions, to what we see about that lesion. So again, the morphology, so is indicated for all the non-granular surface, for lesion more than 20 millimeter, otherwise we'll go with our snare to do it en bloc. But mostly for rectal lesion, we have specific indication because in the rectum there's a high risk of harboring early cancer. And remember that the surgical alternative for rectum are very complex. And because we are in the rectum when the anatomy is different from the colon, and because the ampoule of the rectum is really stable, it's not moving as the rest of the colon, so let's say that ESD is relatively more easy than in the rest of the colon, we have more safety in that area. So let's say that all the lesions that are more than 20 millimeter in the rectum should be resected by ESD. What is an ESD? So it's a surgical technique, is indicated for superficial neoplasia, but requires strong and precise manual skill, but it should be part of a multidisciplinary context because we are removing superficial neoplasia, we are removing cancer. So this is an oncological endoscopic procedure. It's not just endoscopy. And remember that it is associated to an increased risk of complication. Maybe it's too much. So the first two, let's say this is the line, the progression of skillness on the learning curve for ESD. The first, again, is the prediction of histology. Then, of course, you must be already at advanced skillness in performing EMR. And then finally, you can go for ESD. And also for ESD, we have different techniques, the same that we saw for EMR. We have the standard ESD, when we try to go with our scope and our cap just below the lesion to create a pocket or a tunnel. And in this way, we have the tunnel technique or the pocket creation to remove all this lesion in one piece fashion. But we need special device. We said before that compared with EMR, you have special device to be used. You have, of course, the CO2 insufflator. It's mandatory to have it in your unit, otherwise you can't go for ESD. But you need a high definition scope with electronic chromendoscopy because the diagnostic part is the most important. Your scope should have a water jet to be able to clean during bleeding, because you will have bleeding during the ESD. It's part of the procedure. You have a selection of knives, not only one, and then you need a very smart generator. The electrophysiological unit must be very, very important. Usually is the latest series of bio. So let's check with this lesion. Again, it's a complex lesion. Again, the most important part of the lesion is only visible in retroflexion, not in frontal vision. I don't know why we found this complex lesion every time. So because of, I'm not showing all the diagnostic part because it will be too long, but because of the morphology and part of the lesion was non-granular, we decided to remove it en bloc. And because the lesion was more than 20 millimeter, it means that en bloc is an ESD. So we started with injection. Always the injection is outside from the lesion. And then carefully, this is a dual knife, we start making the mucosal incision around the lesion, outside from the lesion, of course. And I will go a little bit further, otherwise it will be too long. And step by step, we are exposing the submucosa to enter with our cap. You can see here we have a distal attachment that is transparent and help us in going below the lesion. Because I used to say that to perform an ESD is like to cut a steak just with a knife without the fork. You don't have, as in surgery, the second hand. You just have one, and you have to cut it in very small, small pieces. How can you do? It's very difficult. You must go under the lesion and create the tension that usually is done by the fork that you don't have. So step by step, adjusting the position, you create the space for your scope to go under the lesion, and very carefully. So that space is very limited, because on your right you have the back side of the lesion and you have not to cut it, otherwise you are not sending the right specimen to your pathologist. But on the other side you have the muscle and you have not to cut it, otherwise you make a perforation. So it's a big compromise between two very risky situations. And step by step, you find your plane and you remove completely the lesion. I will go again. And this is the last cut. Yeah. In this way, look, we are using the gravity because the lesion seems now a polyp with a stalk that is collapsing by the gravity towards the opposite side of the wall. So we are finally injecting and cutting. And this is the end. So why the transparent hood is crucial and essential? Because it helps you in going under the lesion. This is the mucosal cut, so with the cap I enter in the space and I make that tension that I usually don't have. So it gives me a better visualization of the operating field and give me traction. But remember that we also have the gravity, so we can change the position of the patient to apply the gravity and to use the gravity to let the lesion collapse towards the opposite side of the lumen. But what's about safety? Complex EMR in ESD can be very tricky and can be very dangerous. The most serious adverse events that we can have is bleeding and perforation. But remember that also for EMR in ESD, you have the post-polypectomy electrocoagulation syndrome. That is when the patient comes back with fever, localized abdominal pain, but not a real perforation. But the most important for us are bleeding and perforation itself. So bleeding, perforation is about 1 to 2% in EMR, but can arrive till 10% in ESD. And perforation is a deep mural injury. This is the Sydney classification to classify the different type of perforation, but the most dangerous and most important is the type 5 when you have a complete hole. Remember that also in EMR you can have the target sign. Look at this one. This is simple. Yeah, I know, just 1 minute. Okay, thank you. This is not a very difficult lesion. I started at, what time was? 10:52. I was a piecemeal. I finished at 10:59, so it's 7 minutes. I will apply clip just to be sure, but then the patient had a big bleeding and it was 5:30 in the afternoon. So this can happen even in expert center. But also perforation can happen during ESD. So what about if we have a perforation? We should make a recognition because there was a technical or region related that something was not right. We should stop and reflect, we should double check, and we should understand what to do. I had more slides because you know that the topic was not simple to do in 20 minutes, honestly. But okay, I will go no lifting sign when injection is important. I will give you a separate slide if you want, but I will go to my conclusion. That is, the correct endoscopic resection must be chosen after proper lesion evaluation by all of this, the morphology, size, bit pattern, and vascular pattern. But the correct endoscopic resection must be chosen mostly considering the endoscopic skillness and training. ESD, of course, is an efficient technique to resect superficial neoplasm with a low recurrence rate, but it is safe in expert hands because it allows an accurate histology and invasion depth assessment. Thank you.
Thank you, Roberta, for these excellent presentations. I show you that you are smiling. Open your microphone. Open your microphone.
Okay, here we are. Thank you.
Yes.
It's so weird to see on the screen myself speaking, but it's nice. It was a nice presentation. Thank you.
You are very nice, and also sorry for delay. So now it is open to Dr. Ayman. If you have any comment until we receive questions and from the audience, we have first. We have around now more than 200 on the FaceTime and with us, from about 600 which is already registered, but it's about 200 now with us, maybe more on the FaceTime. So maybe we need your comment, Dr. Ayman, if you have comment, and then you can ask about this lecture, Professor Roberta, about anything.
Yes,
Dr.
of
Ayman?
course. Yes. Yeah, yes, of course. Thank you, Professor Roberta, for the very nice presentation.
Yes, we can hear you.
You can hear me. Okay. I would just like to ask, I didn't notice that you did the marking of the lesions before doing the piecemeal AMR or, of course, the ESD. You don't depend on markings, or I just didn't notice that?
We usually mark the lesion. It's a good point. Mainly in the upper GI, but in the colonic lesion, the margins are very clear. So usually you don't need it. You know, you need it in two main situations. When you are facing a lesion on IBD, because on IBD, because of all the inflammation, you don't have clear margins. And also when you have or fibrosis or when you have serrated lesion, because even with serrated lesion, the margins are not clear at all. So in all the situation when you don't have clear margins, in that situation you should mark before, and all the chromendoscopy and the digital chromendoscopy can help you in seeing the margins, and then you mark. Otherwise you can go without marking.
Yeah. And you depend always on the electronic chroma endoscopy, not on the dye, or sometimes use the dye.
Yeah, again, it's a good point. It depends on what you have, honestly, and what type of scope you have. But nowadays, we have this beautiful and huge digital chromendoscopy, and in most of the time, you are able to use only that one without going for spraying any vital colors and adding anything else than digital chromendoscopy. But you can apply both. It depends on you. Most of the time, I don't use the blue or the indigo carmine. I use only the digital chromendoscopy. I think that in the colon is the time where we have, as I said, all the classification. We know, let's say, quite everything about the lesion, and we can assess the morphology and all the things we must know only by digital chromendoscopy. In the upper GI is different, and we need to apply the digital the blue and all the colors we have. Not in the colon. In the colon, we can do also without it.
Yes.
What do you think? Do you agree?
Yeah, I usually do that, but because spraying the dye in the colonoscopy, usually it might disturb you later on when you are doing the excision. So
Yeah.
I usually depend on the NBI and PSLV and things like that.
Yeah, again, in lesion on IBD is different. In that situation, you need the blue because again, the margins are not clear. So you need to add something more than your just digital chromendoscopy to understand where the lesion is ending and where is the borders of the lesion you are going to resect.
Of course. And of course, the methylene blue is a must in the injection, to be part of the injection.
Yes, because in that case, the fact is that the principle is that only the submucosa between the mucosa, submucosa, and muscle layer, only the submucosa get elevated when it's injected. So if you add blue, if you see blue, it means that is the right plane. I used to say to the fellows that the blue is your friend. So if you see blue, it means that you are in the right space. If you don't see blue, there's a problem. Maybe fibrosis, maybe you are injecting the muscle, but it's something wrong there. So blue is your friend.
Yes.
I think.
And of course, I would like to thank you, Dr. Ibrahim, for the slide about the quality in colonoscopy, because quality in endoscopy is very important. Actually, we can't do colonoscopy without good preparation.
No, at all. Not only colonoscopy, but also the resection. Let's say that if I plan a patient and in the morning he comes with a bad bowel prep, I will plan it again. I will postpone. I can't do it because in that case, the risks of perforation and the risks of everything is so high that it's not good for the patient to proceed with the resection. So it's crucial not only for the diagnostic part and to make a good and a high quality colonoscopy, but it's crucial for the resection. Without a good bowel preparation, we can't proceed with the resection.
Yes, of course.
And the patient must know. So is there, let's say, is there priority to have a clean colon, to have a good diagnosis and then a good resection?
Yes, very good. We have some questions also, Roberta, for you. Why C2 insufflation, it's a must in ECD?
Because let's say that we have a perforation. If the CO2 will go outside, it's like a laparoscopy. Later on, step by step, it will be reabsorbed very quickly and very easily without any further complication. But if you are inflating air, the absorption of the air is different and can cause many other complications in the patient. So it's to prevent complication.
Second question, what's your action in the case of perforation when you have a second look?
Usually we don't have a second look. So it's not indicated to have a second look after resection. You have a second look only if something is happening. Only if you have a complication, let's say bleeding, not really perforation. It depends where you have perforation. So what's again the question?
if you have a perforation, you should deal with it at the same time, not waiting for a second look.
Of course. So you have intraprocedural perforation, and you must be able to manage it with clip and with everything you have in your hands, with Ovesco, with suturing, with everything, but you must close it. But you can have delayed perforation. If you are in the colon, not in the rectum, you will see by the sign and the symptoms of the patient. In that case, most of the time, it's a surgical procedure to do something for that perforation. If you are in the rectum, it's a different story because anatomically it's different, the rectum. So in most of the cases, you can manage in a conservative way without surgery, but it depends on the patient. But the most important thing is that after the resection, EMR or ESD, whatever, you must check the bed of your scar, the bed of the resection you've done, to check for bleeding, for visible vessels, but also for very small, tiny perforation to close it.
Okay, what's the question? What is the next step in case of unclear margin?
Before resection, you mean? You must apply everything you have to check that those margins and to understand where the margins are. Sometimes, because the blue helps you every times, if you inject, let's say this happened in the serrated lesion, if you inject the submucosa, then the margin become clearer. So even in this case, blue is helping you. So injecting the submucosa and check the margin. Because of the distension of the submucosa, you will see clearer the margins.
Yes. Ayman, you have any comment on that?
No, yeah, yes. You should use every skill you know to detect the margins.
Most of the time, if you look there closely with zoom, with magnification, if you have, you will be able to check the margins. But if you are not, injecting the submucosa will help you in seeing the margins.
Yes, there is one, I don't know, you know him, Dr. Munir Agil from South Africa. You know him?
No.
He said thank you very much for your lectures.
Thank you.
He's from South Africa, yes. The second one, do you coagulate the bed routine?
Yes, in case of visible vessels, and most of the time you have visible vessels, so I go there, and as I said before, your resection is ending really not when the specimen is out, but when you go there again on your scar and you check the scar for vessels and for perforation. So go out from that body only when you are sure that you've done everything.
Yes. There is. You have any comment, Ayman?
No. And of course you coagulate, and sometimes we ablate the margins with the tip of the snare to ensure that we removed.
Yeah. In case of EMR, it's a very good point because the study we had mainly from the Australian group, it shows that the soft tip coagulation of the margin decreased the number of recurrence, but mainly after piecemeal EMR, because in that case, you cannot be so sure about the margins. And this is why you coagulate them at the end of your resection. In case of ESD, because you are seeing all the margin and you are doing the circumferential incision before going under the submucosa and cutting the lesion, in that case, the soft tip coagulation of the margin is not really indicated. There's a debate on it.
There's another question coming. Do you close by clips after lesion remove every case?
Not every case. I try to clip and to close the scar in the right column mainly. More than the 2 centimeter, I try to close it. But this is not really simple. So you need also skills to close a resected lesion in the right column. So it depends on your skills again. It's not good to say every time it depends, but it's the truth. So there's not a specific and straight guidelines. You must adapt on what you have in your hands. But if you are able and you can close it, it's better to close it.
Yes. Another one, what is the solution used for the ECT or MRI, and what solution? And sixth thing, do you use adrenaline or not?
I always use adrenaline. I don't use adrenaline only when I'm facing lesion very near the anal verge, because in that case, there's the hemorrhoids, and I try not to inject adrenaline in the hemorrhoids because the flow is so high that the adrenaline can go everywhere in a systemic way. And then I usually use normal saline solution plus blue and adrenaline. But if I see that the lesion and the position is difficult, and I will stay there for a long time to adjust my position and my snare or my knife, in that case, I will use something that is very viscous. And nowadays on the market, we have a lot of different injecting solution, like for example, the hyaluronic acid, or we have the Eleview, we have the rice gel, we have a lot of gel that stay for a long time there. And this is good for difficult lesion, and that means difficult position, and also for the training. I mean, then when you have a trainee that will need a long time to do that resection, it's not fast because it's not sure in his hands. So in that case, maybe it's better to use a viscous solution that stay longer. So you won't change and exchange every time the needle or the knife and the snare, because it's not able to do it fast.
You have any comment, Ayman, about that?
No.
Okay. What's antibiotic you used before or after?
Sorry?
Antibiotics. You use any antibiotic before or after?
I don't use it. Again, I use it most of the time when I have in the lower rectum, nearby the anal verge. In that case, I also use prophylactic antibiotics. Otherwise, I don't use it.
And you use it locally or use it orally or intravenous?
Orally. Oh, intravenous when the patient is in the hospital, and then orally when he can discharge at home.
There is some questions coming.
What do you do?
What?
What do you do? Because this is just my experience.
What you do about?
About antibiotic.
Normally, antibiotic, I never use antibiotics when I remove any polyp. Never use it, never. Because I play with polyps since more than 40 years, but it was a bilharzia polyp, like it's the same. If you do complete your work is very good. I never use maybe an injection or a screw therapy or band ligation. We use antibiotics. But after polypectomy, there is no need at all, except you have a complication like perforation or something like that. But normally, I never use it.
Yeah, this is the other situation when I use it. In case I have a complication, a perforation during the procedure, then I do the antibiotic.
Yes, very good. And I was more happy by what's called the second look, which is very good. You don't make a second look if you are doing everywhere, because they ask if you have in the second look what happened here.
No, okay. You don't need a second look. It's not indicated.
Yes, you should. There is only, we will go. I would like to say something. All the questions will be answered at the end. So if you cannot answer some question now, we will have a time, because there is many questions coming, many. So what I will spend by two things. One question is, what's about submucosal resection in early margin lesions?
In early?
Yes, you can look for this question. You can look for these questions in the first one. What's about submucosal resection in early malignant lesions?
Yeah, this is what we were talking about.
Yes.
We should approach every lesion as an early malignant lesion. This is why it's better to do it en bloc if we have the features of malignant depth of the lesion. And this is why we go for ESD for the early malignant lesion. If you think that is early, let's the word say, you go for endoscopy. But if you think of during the procedure, you see that there is something attached to the muscle that is not so early, maybe is infiltrating in the muscularis propria, then you should stop. We should know our limits. So if it's too that, we should stop and send the patient to surgery remove just a part to have the histology and send the patient to surgery. But if it is an early malignant lesion, we'll go for ESD or EMR if the lesion is small.
Okay, thank you, Perla. Thank you, Ayman, very much for this, for the lecture and for discussions and for comments. We still have many questions, both of you. Some of them coming from Tunisia, Libya, and some questions also coming from Africa. So, but the man from South Africa, he said that he liked to thank you very much for your lecture. So I will remember his name. I will send his mail and name to you.
Okay.
Now, I like to say something. In my lecture, I speak about Norgine, about their relation to colonoscopy and what is important. But nobody asked me why you speak about Norgine and you are in a Sino sponsor webinar. Nobody asked me these questions. Why?
I asked you, why are you speaking about Norgine if you are in a
Because now Asino, now she take Norgine.
Okay.
Now Asino, now it is Norgine, now it's honored by Asino, and from the beginning now Norgine become Asino now.
Okay.
So yeah, so Asino now it's starting by working in Egypt and all the country by the name of Asino. She already take Norgine. So nobody, because I don't speak about except Norgine, but I was suspected somebody to ask me why to speak about them, because now it is everything, it is done by, it's called now Asino, no Norgine again. Okay, so we waiting for your lectures now. The second lecture from Italy about endoscopic management of GERD. And then I promise that all question and the comment will be answered.
Okay.
So your lecture and live, okay? You can start your lectures.
Okay, let me share my screen.
Yes.
So my lecture is about the endoscopic management of GERD. I will give you just an overview of what we can do for endoscopically for GERD. So I will give you, let's say, the pills of what we can do. Just to have a background that the GERD, the gastroesophageal reflux disease, is one of the most common gastroenterological disease in outpatient clinics. And the PPIs are the cornerstone of the treatment of GERD. But 1/3 of patients have a suboptimal response to PPI. And what can we do if the patient is not responding to PPI? Up to now, we had only anti-reflux surgery, but now we can include also the endoscopic anti-reflux treatments. The anti-reflux surgery is not popular due to the invasive nature and also the adverse event that you can encounter after surgery. And this is why the minimal invasive endoscopic anti-reflux therapy are gaining popularity for the management of the PPI dependent and PPI refractory GERD patients. If we compare the two, the endoscopic therapies are less associated with complication, and we are talking about dysphagia and gas bloat syndrome. But the anti-reflux surgery remains the ideal treatment in patients with a large hiatal hernia. So we are talking and we are targeting the patient only without a large hiatal hernia. Also the patient with morbid obesity, where the gold standard is the gastric bypass, and also severe reflux esophagitis. The endoscopic bear the potential to narrow the treatment gap between PPIs and anti-reflux surgery. So basically we have three groups of endoscopic treatment. We have the radiofrequency ablation, there is the stretta, the endoscopic fundoplication, and we have three different types of endoscopic fundoplication, or an endoscopic procedure that try to mimic the laparoscopic fundoplication of the fundus. And then we have also the endoscopic mucosal resection. In the market has been launched many other modalities, like the injection of bulking agents, like the Enterix, the Plexigas, the Durasphere, and also some other endoscopic suturing, like the Endocinch and the NDO applicator. But most of them, they have been withdrawn from the market for the pure efficacy and also for safety concerns. So this is why I group these three: the radiofrequency ablation stretta, the endoscopic fundoplication, and the endoscopic mucosal resection. Talking about the strata is the delivery of a thermal injury energy to the muscle of the LEs, and the gastricardia is a 4-channel radiofrequency generator and this catheter system with 4 needle electrodes. It gives low temperatures, that means 65 to 85 grades to the muscularis propria and 35 to the mucosa. And the mechanism of this strata is to increase the gastric pressure and the thickness of the left muscle and decrease the gastroesophageal junction complex. So the junction is tightened and the reflux is minimized. If you talk now about the second group, that is the endoscopic fund application, we have mainly 3 different treatments. It is the Esofix, the GERD-X, and the Muse. There is something combined, endoscopic and echoendoscopic EUS ultrasounds. Let me go to the next slide. I put this table just to understand the 3 different endoscopic duplication, the TIF, the GERD-X, and the Muse. In all of them, we have an improvement in quality of life. And if you look at the results, the cessation and the stop of the PPI use is about from 70 to almost 90% in all of them. And also the Demister score, there's an improvement in all the 3 different treatments. And again, the esophageal acid exposure time, the improvements in esophagitis, but they are, let's say, new treatments. So the follow-up available is up to 6 years only for the TIF, but for the Muse is 4 years, and very, very recently for the GERDs. So we need more data to say that these treatments are effective and safe. And if we look finally also at the adverse events, it can arise up to 14% to the Muse because this combination of endoscopy and ultrasounds. More recently, we have again from this genius, from this Japanese doctor that is professor in Norway, he developed the ARMS. This is the anti-reflux mucosectomy, was initially described by him. And the principle is that mucosal defects that you can achieve with the mucosectomy, so with an EMR in retroflexion of the cardiac region, leads by healing of a scar formation that induce narrowing of the gastric cardia opening. Is a EMR of half to 2/3 of the circumference of the gastric cardia, is performed using endoscopic submucosal dissection or piecemeal EMR, very simple. And very recently, we have the ARMA, the anti-reflux mucosal ablation. In this case, just ablating the area, it showed a shrinking effect that is similar to ARMS. So without going for a resection, we go only for ablation. And it seems that the results are very similar between the 2. So let's say that we can talk about an algorithm. If we have patient that is not responding to the standard dose of PPIs, we should rule out any other causes of symptoms by an gastroscopy, an esophagogastroscopy, and esophageal manometry. And then we go for pH study and impedance. If it's normal, we should not do anything but just consider alternative diagnosis, but we can have acid reflux or non-acid reflux. In case of acid reflux, is the patient willing to take PPIs even for a very long time? If the answer is no, we should go for endoscopic treatment if the patient is suitable, or we should optimize PPIs in case the patient is waiting. Same for non-acid reflux. So the endoscopic treatment is just filling the gap between not responders to PPI and surgery. We have finally some weapon in our hands that is different from surgery. So endoscopic modalities, this is the pills, have been found to be effective in a selected group of patients. We said small or no hiatal hernia, absence of Barrett esophagus, and no morbid obesity. Patient selection is crucial to obtain optimal results with endoscopic treatment that is currently available, and more will come on the market. Morbid obese patients and patients with large hiatal hernia are best managed with anti-reflux surgery. In this case, is a gastric bypass or laparoscopic Nissen fund duplication. And these were the pills of the endoscopic management of the GERD.
Thank you very much, Berta, for this simple introduction. I ask you to be only a simple introduction to let, yes, a little bit, which is very good, but it will stimulate question and it will stimulate something. So now we present a live cases of endoscopic management of GERD, and then we'll open the discussions. Still, we have some questions from, and then we'll continue the discussion. So now we present a live case for GERD. So we can present it now.
The next case is for a female patient, 34 years old, with refractory GERD, more than 5 years, with vomiting, not responding to PPI. Upper GI shows GERD grade A, small striding hiatus hernia and gastroduodenitis. The manometry shows small striding hiatus hernia and hypotensive LES.
The new procedure, which is called ARMA. ARMA means anti-reflux mucosal ablation. I showed you in my lecture yesterday the procedure called ARMS, that is anti-reflux mucosal resection, mucosectomy. But by this procedure, you do not need a previous experience of doing EMR, because here you can achieve the same result of tightening the lower esophageal sphincter or remodeling of the LES by simple ablation. But you cannot do the ablation by using APC, argon plasma coagulation, because by doing APC you do only a very superficial mucosal ablation. Here we have to do an ablation up to the muscularis propria, up to the muscularis mucosa. The muscle layer, the major muscle layer, muscularis propria, has to be kept intact. So we are using a triangle tip knife from Olympus, TT. I've taken a U-turn now, and the first step is to do a marking. And we have to mark the area which we want to ablate. And the marking is done in a butterfly fashion. I want to show you that this is the fundus of the stomach, and this is the greater curvature. So you leave certain portion of the fundus area. I'll demonstrate to you now which area we leave intact. We don't ablate. So I'm passing the TT knife now through the scope.
We are ablating the mucosa or the submucosa or the muscle layer?
Ablating the mucosa up to the muscularis propria. You see this area? So this area we are leaving intact. We are not going to ablate. Now how much area we leave intact? The same diameter of the scope. So that becomes elastic. And the rest of the area on the lesser curvature side we ablate. And that area which we have ablated within a month heals by secondary intention, and you develop a nice cicatrization on the lesser curvature, and at the greater curvature is pulled up like a sling. So this is actual remodeling of the LES. So now the marking I'm going to do now. So I'm going to use, for the marking also, we are using a spray coagulating current. So first and foremost, most important step is proper marking.
How do you know that you reach the muscularis propria? And it means that is contact, maybe 1 second only.
What?
How do you know that you reach the muscularis propria? Because you said it should be...
Oh, you should not be able to see the muscularis propria. If you see the muscle layer, that means you have gone too deep. Now first thing let me do is, for that it is necessary that the scope can take a proper U-turn. Okay, hold it here. I'm going to give a little insufflation, suck out the smoke.
Can you tell us what scope are you using? Because this is a very
I'm using the 170 series Olympus scope.
because to get this angle at that close with that degree, it seems that a little difficult with the regular scope. Is that has a sharper angle, or just a conventional normal scope?
Like a normal scope. But you need a proper U-turn. Too much smoke, huh? So sucking the smoke now.
What about the setting
And we
of
clean the knife also.
the electrocutter you are using? What about the settings?
The settings?
Yes, this is not ABC.
What are the settings? No, this is spray coag, no? CO2 is short. CO2 is shut. Spray coagulation, effect 2, 50 watts. It's very important that we have a scope which takes a proper U-turn.
يزيد بقى في الحرق، بحرقها خالص يبقى خلاص هو ده المطلوب يعني. بس يخلص الماركينج واول ما يبدا يحرق شيفت. يعني مثلا دقيقتين ثلاثه. دقيقتين ثلاثه وشفت وبعدين ارجع تاني. بعد دقيقتين. عشان يخلص ماركينج ويبدا يحرق.
Can you tell us a little bit more about the basis for the marking? What exactly are you marking?
I am marking the area which I want to ablate.
And why do you have to do that?
Because that will give you a guideline as to where you are going to do the ablation. You cannot do an arbitrary ablation.
So,
You can see the OG junction now. You can see the junction of the columnar and the squamous epithelium. You see that? It's a wide OG junction.
But what guides you? I mean, what guidance are you using to make your marks? You just is there any particular guidance, or you just go around the circle, around the sphincter?
Yeah, go around in a circle. You see that now? How we have covered the entire circumference? Now what I'm going to show you is okay, now we complete our marking on this side. Oh, don't push, don't push. It has to look like a butterfly.
Yeah, butterfly, it looks so, but where are the wings going towards the lesser curve, the
I'll show
greater
you.
curve?
Are you seeing something?
Yeah, now we are seeing now. Yeah.
You see how
Yes,
I've
yeah.
started ablating now. Ablating the mucosa. And the mucosa has to be ablated with spray coag current.
What did you
During
ablate the
this
mucosa with
procedure,
again,
you need a
please?
continuous flushing. You need to wash that area. And you have to take out the smoke.
Is that a radio frequency ablation? Is that a radio frequency ablation or what?
Not completed. Almost completing. We have to do it in a butterfly shape.
No. What did you use for the ablation? What exactly?
We are
Just
using the
cautery
TT
or radio
knife.
frequency or what?
Triangle tip knife. Yeah. Triangle tip knife and herbe cautery. I'm using spray coag current. Endocut effect 2 and the spray coag 50 wattage.
I think the audience need to know a little bit more about the methodology. Because we asked you a question earlier. How can you tell that you reach the muscularis propria and
You
all
cannot,
that?
you cannot know that because you should not expose the muscle layer. You should not ablate so much that you start seeing the muscle. Because if you start seeing the muscle in that area is very thin. Then you can easily create a micro perforation. So this much is sufficient. You can see a necrosis of the mucosa, proper sloughing of the mucosa, and the muscularis mucosa.
The next case is for
Okay, so now we return back, and this is a lectures of endoscopic management of GERD, and we'll give you a sample example of one of the treatment of GERD with arms. And now we have many questions, but I let first for Dr. Ayman and Dr. Robert to discuss about that. Okay?
Yeah, I really think that the ARMA is a very nice and let me say simple technique. It's simpler than the other techniques that I showed you because you can do it with simple devices that usually you have in your endoscopic room without going for any further complex devices to be and delivered in your unit. And the mechanism and the principle under the technique, it's really smart because of the cicatrix and the healing that you will have after the ablation. If you ablate just 2/3 of the circumference, leaving the normal mucosa for the elasticity of the tissue, you will have the tightness of the junction. Let's say that this has been published only as a pilot study at the beginning of this year, in January 2020. So we really need more data to say that is really effective in the long time. But the data that we have till now say that it is effective and safe for that selected patient that I said, so without a hiatal hernia and without severe reflux esophagitis, but at the same time, they are not responding to standard dose of PPIs. The point is that mucosa that should be ablated is the gastric mucosa and not the esophageal mucosa. You should avoid the esophageal mucosa, otherwise you will have a stenosis, you will have a stricture, and you have dysphagia. Because I saw that one of the questions was what are the side effects of the fundoplication and the endoscopic treatment of GERD? One of the dysphagia, that is the same adverse events that you can have with the anti-reflux surgery. So it means that you have tightened and closed the junction too much, and it's true that the acid and the non-acid is not able to come back in the esophagus, but at the same time the bolus and the food is not able to go down, so it's tightened too much. This is one of the main side effects that you can have if you strain too much the gastric esophageal junction.
Dr. Ayman, have any comment on
yes,
the lectures?
I would like to ask Roberto about the efficacy, because in ARMA we don't know actually if we did well or not during the procedure. We don't know if we already ablated the submucosa and we didn't reach the muscularis. Do you think, what about the efficacy comparable to the mucosectomy? Is it the same efficacy or it's a bit different?
So again, we don't have enough data to say. The fact is that in the arms, so when you are doing the resection, you are able to see the muscle. So the healing you will have is for sure about the mucosa and the submucosa, that while healing, they will close the gastroesophageal junction. In the arms, you are trying to be not so superficial as in the APC treatment, but at the same time, you are just ablating the mucosa and just a part of the submucosa. You don't know how much deep. So we still need more data to say about the efficacy, and mainly the long-term efficacy, because for sure you will have an efficacy in the short and mid-term, but we don't know yet about the long-term. And because we are treating patients that they are no more responding to PPIs in the long-term, this is our main goal, to respond in the long-term, and we don't have data to say.
Yes. And have you tried doing mucosectomy with the band ligation? Because in Egypt, you know, we are using the band ligator for many things, for the viruses, and we are oriented in mode of therapy.
Smart, and you can do it as you do for example, for Barrett. It's the same principle. But I tried only with the captivator EMR, with oblique cap and with injection, and then lift and cut. But not with the band ligation. But it's very smart. You can do it because it's something that you already know for the esophagus, so you can apply it in the gastric junction.
Okay, one question is not is for me. We have many questions from audience, but for me, many of the doctors and many of the patients ask, when you advise your patient to go to make endoscopic treatment of GERD, for you and for Ayman. Start by you.
Say it again.
When you send your patient to do endoscopic management of GERD, what's the situation? You are a patient with GERD.
Yeah.
What's the patient you send it?
So I usually start to understand if it's only reflux. So I will go for gastroscopy to rule out any other possible causes, and for pH monitoring to understand the pH of the liquid that is refluxing in the esophagus. And then I will start as usually with PPIs. But if in the long term the patient is not responding to PPIs and I didn't found any big hiatal hernia, the patient is not morbid obese, so we have all the selected cases that we can apply the endoscopic treatment, I will suggest the patient for the endoscopic treatment.
Ayman?
Of course, I agree perfectly with that, with the Professor Roberta said. I will just add that I'm going to sit with the patient and tell him about this option. And it's an early study. We don't know the long-term consequences of doing that. But I think if he's dependent on the PPI for a long time, I would like to tell him about this option.
Yeah, and you know that you know better than me that most of the time, if you interrogate the patient very well, you understand that the patient is not taking the PPIs properly. Maybe he's taking after lunch instead of before lunch, or is not following any type of diet for his reflux, and just adjusting these two, the patient can go well. But we have some patients that really, they do not respond to PPIs. So in that specific case, with not responding, no hiatal hernia, no morbid obesity, you can suggest any endoscopic treatment before go for surgery. So at this moment, because we don't have long-term follow-up, we can say that the endoscopic treatment is in between the PPIs and surgery. It's just in between. If it's not working, then we still have surgery that can work. This is my opinion. I don't know if you agree.
Yes, it's okay. But these questions, because you said what is very important is adherent. Because many patients, yes, so you touch a very good point of patient, because the patients come to us and he's still complaining, but when you discuss with him, he's not adherent to drugs.
Yeah,
he's not taking the drug.
It's not working, but it's not taken properly.
He's not adherent in the proper way, in the proper dose, or every day, or before eating. So this is one of the main problems of failure, is adherent to management. So I agree about that. Dr. Ayman, you have any comment about that? Ayman? Ayman? He's not with us. So we will start.
I want to add one more thing, is that we should aware the patient, all the reflux patient, that reflux is a chronic disease. Then sometimes you have some upper waves and sometimes you are fine, but it's a chronic disease. And even if you go for endoscopic procedure or for surgery, that is up to now, let's say the gold standard, it will not solve 100% the problem. So it must be adherence to the diet, to PPIs, and to all the management that we are suggesting to him, because it's a chronic problem.
Okay, Ayman, you'd like to add something?
Yes, of course. Many of the patients are actually, after doing even surgery, will need PPI.
Yeah.
Nearly 50% will need PPI after 5 years. So it's not, it's a chronic problem, and it's not, cannot be solved only with surgery or endoscopic management.
Okay.
I think multifactorial issues should be addressed to the patient.
Before we go to another question, please.
No, it's okay. I was just adding that we should let him understand that even surgery is not the magic solution of the problem. Reflux is a complex problem due to lifestyle and not only lifestyle, but also the motility of the gut, of the upper GI tract, the esophagus, but also the stomach. So sometimes if you add to PPIs also the procinetic, something that helps the delayed, the gastric emptying of the stomach to get faster, you can solve the problem. So you must adjust the therapy, and the endoscopic therapy is just part of the therapy of the GERD to the different type of patients.
Okay, before we if the patients need to be endoscopic management by GERD, you have one choice. What is the choice you give to him? What type of treatment, endoscopic management? You got one priority, like something like that?
So
it's a difficult, and I know that.
Yeah, it's difficult, and it depends on different factors. Factors related to the patient, and also factors related to your skillness and what you have in your unit. Because we said that ARMS and ARMA are easily achievable with simple devices. Otherwise, the other endoscopic fundoplication or strata, you need to buy complex devices. And complex devices means that also the learning curve in understanding how they work and how to use them is complex and is long. So it depends on you. If they came to me, I do not perform in the unit where I'm working the endoscopic fundoplication. I can't offer to the patient the endoscopic fundoplication, but I can offer the ARMS and the ARMA. Otherwise, I can offer, for example, surgery. So it depends on what you have. But if you want an answer about what's the best, up to now, they are similar, and we don't know for the long-term follow-up. So there's not a clear answer.
Okay, Ayman, Professor Ayman?
Yes, of course, except for the part of the hiatus hernia, I think. If the hiatus hernia is the smaller than 2 centimeters, so sure, we can go for asthma and ART. But if the hiatus hernia is large, we need fundoplication, of course. Our mouth will not do well.
One more thing is that these factors that I said, they are related to you, to the endoscopist, but not to the patient. But we should look also at the patient, because the endoscopic fundoplication is done in general anesthesia. So if the patient is old or is unable to go for a long procedure that is about 1.5 hours or 2 hours, so you should go for something simpler like ARMA or ARMS. So again, you have factor related to your skillness, to the availability of the devices, but something also related to the patients.
Okay, so we return back to the questions. The first one, you can read it. What's your opinion about treating residual after EMR by ABC? That's correlated with high recurrence as suggested by some study.
Yeah, it's true. So the APC is not good. You apply the APC, and also the soft T coagulation is similar, not for the residuals, because you should remove all the lesion you see. This is why to see the borders and the margin is so crucial and is so important. So you really, you go to coagulate the really small cells that are remaining, but not the real clear margin that you should remove and send the specimen to the pathology. This is why just applying the APC randomly, they don't go for good results in terms of recurrence.
Okay, the second coming from Tunisia. Any experience about Eisner?
Eisner, what is it?
I don't know. This is a lady. This is a lady from Tunisia. Any experience about Eisner? What's Eisner? You don't know, huh? You know something about that, Ayman? No, huh?
No.
So she listened to us and she can ask again.
Okay.
In chronic resection, if air under the diaphragm and perforation cannot be seen, what next?
Air under the diaphragm means perforation. So you have also other clinical sign. You have an acute abdomen, so you should send the patient to surgery. Unless you have very tiny air. That means that you have a micro perforation that is something very small. But for sure, the patient must be hospitalized. You must perform a CT to understand where the perforation is. You should know because you remove a lesion, so you know if it's the right colon or the left colon. But we were talking about something before to have the air under the diaphragm, how to improve our skillness in preventing the perforation, not how to manage the perforation. The perforation must manage as every type of perforation, like the perforation after the opening of a diverticulum. We should prevent the perforation in the resection. Well, once you have it, you must manage in the perforation way. I mean, together and alongside with your surgeon.
Yes, Dr. Ayman, you speak about anticoagulant.
Yes.
Anticoagulant and procedure, yes. Two questions about
according to the procedure we are going to do and the type of the anticoagulant the patient is receiving. We have many different types of anticoagulants and antiplatelets. If he's on the new oral anticoagulants, you could stop it just 48 hours before the procedure. But if he's going on warfarin, you should stop it for more than 3 days at least and check the INR before doing the procedure. And of course, the second part is according to the procedure itself. If it is a complex polyp or a simple small polyp. Yeah, you know, many of the small polyps are now removed by what we call cold snaring. And it's a very simple procedure and it's not associated with much bleeding. So if it's a small polyp, we can just do with polypectomy and the patient just stop the anticoagulant for 48 hours. But if it is a complex procedure, I should check everything before doing this complex procedure and stop the anticoagulants before more than 48 hours. Check the general condition of the patient. Should we need to resume the anticoagulation just after the procedure, or we can wait for a little bit after? So it depends according to the procedure and the type of the anticoagulation.
Any other comment, Robert?
No, I agree. We have a lot of studies they are coming about when and how to stop the antiplatelets and the anticoagulants. And it also depends on the condition of the patient and why he's taking the drugs. Because for some cardiac or heart disease, we should take again the drugs as soon as possible, not to give any thrombotic possibility to the patient. So even in that case, it depends on what we are doing, how long will be the procedure, how risky of bleeding will be the procedure, and patient condition. That lady, she sent us the link of the Eisner, so I check it. I use it from a different company. It's not called the Eisner. The Eisner. She sent it. It's a combination of the snare together with the needle. So
she sent it to you or the question?
No. She sent the question. She sent the link. If you go to the question, you will see the link.
Ah, very nice.
So I tried. It's very smart.
Woman endoscopy.
Yeah.
Very good.
Smart. So yeah, it's very good. I tried it's useful for piecemeal because instead of exchanging your needle and snare, you just you have two different hands. So with one hand you open the needle, with the other ones you open the snare, and so you can open with your nurse what you need. For the piecemeal, it's perfect.
So we like to thank her very good because this is mean that we are alive. Our communications are very good, and I like that.
Yeah, she's the proof that we are live and we are practicing.
No, she proved also she's right. And we said something which both of me and you and Ayman, they don't need. So it is very good. I think this is one of the very good things in webinar, that you have different people from all over the world discussing you at home, something you are eating. Okay, thank you, Sami, for that. What is that effect of Gerdix fundoplication in your opinion?
Yeah,
in your opinion, it's effectiveness.
Before, if you close the junction too much, you can also have dysphagia. the same that you can have after surgery. This is why we were talking and we are saying that you should ablate or resect, but anyway, you should work only on the gastric side, because the elasticity of the gastric mucosa is different from the esophageal. If you touch the esophagus will healing as a stricture, but not in the gastric side. In the gastric side, you want to have that stricture because you need to close the esophageal junction, but not on the esophageal side. So again, it depends on you. If you go too much on the esophageal side, you will have stricture, and stricture means dysphagia.
Can ARMA perform more than one time?
We don't know. It's too early to say.
It's
Theoretically, it should, but we don't know. But if you need more than one time ARMA, it means that it was not effective. And why it was not effective? Because you didn't ablate enough, or because the ablation was not effective. So we have a lot of questions open and we don't have data to answer yet.
Very good. Another question is coming from WhatsApp. For large hiatus hernia, if ARMA is enough?
No. Because in case of the hiatal hernia, it means that part of the fundus is in the thorax. So only the surgeon can just cut all over the esophagus and put the fundus in the proper position. It's a surgical treatment.
Dr. Ayman, how long the PPI can prescribe in GERD?
Good question.
Yes, of course.
But I know Ayman, he can answer it. Okay.
I know.
Of course, it's different if it is an erosive GERD or non-erosive GERD. If we have an ulcers or high-risk ulcers, we can give it for 6 to 8 weeks with the full dose. And then when to stop the PPIs there are too many ways to stop the PPIs, or to use it on demand therapy, to doses per week therapy, which might be. The only guidelines might be in the Barrett esophagus, where if we have Barrett esophagus from the GERD, we can go for life use of PPIs. However, we should know that it might have side effects, and the incidence of adenocarcinoma in Barrett esophagus is not that high. It's only 1 to 2%. So it's only a guideline to take the PPIs in Barrett esophagus, but we should always start to stop the PPIs at a time. We should try to make the patients do other things like lifestyle changes to try to stop the PPI.
So any rule for vagotomy in GERD, Roberta?
No, not really, because the vagotomy is associated with delayed gastric emptying, and when, for example, together with the Nissen fundoplication, the surgical procedure, they accidentally have a vagotomy, then the patient is very bad with the gastric emptying, and you have other problems. So let's say that the motility of the upper GI is something very complex. This is why I was stressing the fact that it's a chronic disease, and we really should talk deeply with our patient to let them understand what they are and what we have in the future, because it's not a magic solution. They can be very complex. So I think that there's no space for the vagotomy. What do you think, Ayman?
Yes, no role, of course. Actually, it might worsen the GERD.
Yeah.
Doing a vagotomy, it might delay the gastric emptying and increase the possibility, the time, the reflux. So it's actually, it will be more worse for the GERD.
Yeah.
Right. Okay. Sami, again, return back to you about the eyes clear can be used, the tip for ARMA. She gave advice now, which is good. Which is very good. The last questions, which is very nice one. This is a nurse, a lady nurse. It's a pre-operative nurse. She joined us. I don't know from where, but I think maybe from Saudi or Emirates. I don't know from where, but she enjoys thank us for all the presentations. And this also a very good that some of the nurses are with us, which is very good. I like thank you, Halima, for to be with us. And I think the problem that why many lady coming to us in this webinar because of Roberta, that she is the king of yes. She is creating what's called the woman endoscopy, which women endoscopy nurses and women. And I think this is a very good idea. And I think when you are dealing the first one in Egypt, I think we will do the second one also in Egypt. The people like that, and this is a very good, I think, because I was doing what called the soft scale in Saudi Arabia for many time, and they asked me, can you give a lectures, not me, but one of the people called the scale about women at the leadership. But I'm afraid that time to speak about that in Saudi Arabia. But what actually happened on live is since 2 years, it's full and very good discussion between lady and men about it can a lady be a leader. It's given by one of the very nice lady of soft scale. I think you know her, which is give the same soft skills in Dina. Yes, she gave another lecture in Saudi Arabia about leader. Woman can be a leader, which is very good. So I think you create something which is good. We have another question. You prefer, Ayman, do you prefer specific BIF drugs for long term of GERD? And you can combine drugs with PPI or H2 blockers? Ayman?
There is no actually big difference between the different PPIs. There is no big difference about them. Maybe the duration of the PPI with some of them is longer than the others, like esomeprazole is a little bit longer duration than the other PPIs. However, actually, no big difference between the PPIs. Adding H2 receptor antagonist, it was actually designed for what we call night acid breakthrough to use the H2 receptor antagonist combined with the PPIs. However, H2 receptor antagonists have a very rapid tolerance, so are not useful on the long term. They can be used only for 2 or 3 weeks. After that, they lose their effect. So we don't need them. We don't need H2 receptor antagonists. The best way is to use PPI together with some changes in the lifestyle that will help to improve the symptoms of GERD.
Any comment, Berta?
No, I totally agree. We know from the history of medicine and surgery that PPIs really changed surgery, because before PPIs, we saw a lot of gastric ulcer and perforation by gastric ulcer, and PPIs change everything. So we have this really powerful drug in our hands. We should use it properly because they really works.
Okay. So I think we pass through many things for lectures, for another lecture of GERD live, and also my lecture on the history of colonoscopy and my history also, which you like all the people know. I think we very good discussions, very good comment, and the nice things that also we receive many questions from ladies, from women, which is very nice also. So we think that we should, because I did many webinar, the lady is not too much like today. So this is very nice that you have many questions from all over the world, especially from Arabic country. So I would like Roberta to be with us. It's very nice. I know that is very late to you, but sorry for that, for what happened.
Thank you for having me. Really, thank you. It was a great experience. Really honored to be here with you.
Thank you. Ayman, also, I'd like to thank you very much for your comment, for your discussions, and for everything. And I hope that we can meet again. Thank you, Ayman.
Thank you very much. It was a very nice meeting.
I'd like also to thank Asino company for sponsors this webinar, which is, as I receive many WhatsApp from them now, they are very happy by the scientific part of this one, and also organizations part. And also, I am said to you now, Norgine become Asino. So Asino now It is control everything from Norgine now, which is very good for us in Egypt because we have some problem in maybe prep and maybe quality disappear for sometimes because the company is out now. Everything will return again to all the Arabic area by that Asino ticket Norgine with her. I'd like to thank all the people behind the camera, Nuran, Marwan, and Heba for this activity. And I let everyone, if you like to say something, I start by Roberta, if you say same thing before we finish.
No, I would like again to thank you and to thank all the participants. And if you said that there was a lot of women, I'm very glad. Thank you for being here with us in these 2 hours and be fantastic for me. I think it was the same for you. And I I hope that I will be able to see you physically very soon. But
sure.
This Corona period really helped us in understanding that we can interacting and share our knowledge in a different way. So let's take the positive things that came from Corona.
Yes, we will meet in December.
Okay.
Inshallah. Ayman, you'd like to add something?
Of course, in December, you should stay in Egypt a little bit longer.
I will try.
Yes.
Okay.
You'd like to add something, Ayman?
Thank you for the meeting. It was a very nice meeting. Thank you, Dr. Roberta, for being with us.
Thank you. Thank you.
Okay. So thank you, all of you. Please go. And please, Roberta, sorry again for late.
No, it's okay.
I know that. So thank you very much and see you very soon. Thank you for all the people. Thank you for Asino and bye.
Bye.
See you.
Have a
Bye.
good night.
Good night. Bye.
Ciao.
Bye.